Happy Friday, everybody. Welcome to yet another RLR. Today, thankfully, that RLR stands to be true. Prof. Rez will be joining us momentarily. I am in my car outside my dentist's office because unfortunately having some acute dental problems, so hoping to be seen. There's a small chance that I will have to dart out in the middle of this meeting because um I might be able to hop in to see them. But Prof. Rez is here to save the day, hopefully soon. I am excited because we have another guest presenter, but before we hand the mic to get to know our guest first, I'd love to thank the core group of people who are making it happen and hear from them a little bit. First from our scribe Zachariah, who is just on his way back home, as I learned. Zachariah, what's new with you? Update the VMR family on how life is treating you.
Hi everyone, I'm Zakaria. Currently working at a new hospital for a couple of months in South Africa, and yeah, it's really great because I now have access to things that I didn't before, like BiPAP and learning about ventilator settings and all of that. So it's quite fun.
That's incredible. What do you think the most eye-opening thing that you've learned in the last few days has been?
Yeah. I think it's been in funny many ways to sort of have almost a mini ICU rotation and see some
Yeah.
really sick people, and
Hmm.
yeah, just getting to experience that side of things, and see how quickly people can deteriorate if not managed quickly has been quite fascinating.
I know, right? Like that natural history of diseases sometimes is really you don't get to see it unless you're there a lot, and if you're exposed to the circumstances that you're exposed to. I love that. I'm so glad you get that exposure. My wife is in a very similar learning environment right now, and almost said something identical to you yesterday while we were reflecting. But let me hand the mic to Gerardo. Gerardo, what's new with you?
Hello, Ravi. I'm very happy right now. And yes, I'm a medical student from Peru. And yeah, I'm very happy to be here.
I'm thrilled to have you. Gerardo's been doing incredible things. And all you have to do is follow him on Twitter to see one project after another, after another, after another. And his most recent tweet was some of his accomplishments along the way, including his many CP solvers discussions. So I highly recommend you check it out. Um, in the meantime, while we wait for Profess to hop on, I'm very, very glad to say that we have a guest presenter today, Jeffrey. It's really, really nice to meet you, Jeffrey. Why don't you tell us a little bit about yourself?
Thanks so much for having me today. I'm Jeffrey Shen. I'm a first year faculty in rheumatology here at Duke. I've been interested in clinical reasoning for a long time. Actually, one of the main things that brought me into medicine, similar to like kind of Robbie's story, is that I watched House when I was growing up, and then I got into Lisa Sanders. Her
Wow.
Think Like a Doctor column really inspired me, and so been interested in clinical reasoning ever since. And at Duke, I focus a lot of my interest and research in sarcoid and also the overlap between neurology and rheumatology.
Wow.
And I also run the case conference for Duke Rheumatology. So I'm
That's
so glad to
incredible.
be
That is
here.
so cool. It's so nice to meet you. Wow. I mean, I think our clinical interests are very, very much aligned. It's so rare to see full-fledged attending on this platform. We're very, very excited for that. I think clinical reasoning is something that I think enamours everybody in their medical training to some extent. But I think that as exposure grows to other things, people tend to find other loves and passions. So it's pretty rare that as a rheumatologist, as anybody really, that you continue to retain that. So tell us a little bit about how your interest for clinical reasoning never faded.
I think I just have been passionate about it, and
Mm.
I think in medical school, like in the first few years, without much exposure to clinical reasoning, it may have faded a little bit. But once I started going into the rotations, and I saw how, the things that I was imagining, that I was inspired by, actually, do come. I trained at UAB, and there are a lot of great
Yeah.
clinical reasoning
Wow.
teachers there, and
Yes.
studied under Bob Centaur and
Wow.
Martin Rodriguez. And so I think I was just inspired by the faculty that I had a really honorable and pleasurable experience working with. And I guess I don't know if I would say I'm a full-fledged attending now, but I guess, being a brand new faculty, I've not lost that spark yet. So hope to keep that as well for the rest of my career.
Oh, you and me both. I still feel like a junior faculty member, but we do have, in fact, a professor of medicine in the house, and that is full-fledged attending Prof. Rez. Hi.
Good morning. Hi, Dr. Shen. Do you prefer Dr. Shen, Jeffrey, Jeff?
Jeffrey's fine.
Jeffrey, okay. Nice to meet you. Ravi, I have the greatest story for you for RLR, though. I can't, it's so funny, dude. It just happened.
Oh no. Alrighty. I guess I have to wait till Sunday, but that's fine, Prof. Rez. That's fine. Prof. Rez, I was telling these folks that I am parked right outside my dentist's office in case they're able to see me. So I might have to hop off in the meeting, and if I have to, that's okay. We'll figure something out. But I feel like we should rock and roll and get the nerding going. So Jeffrey, whenever you're ready, we can hop into your first aliquot with Zachariah, sharing your screen whenever you want to rock and roll.
Okay, awesome. Sounds good. So first aliquot. So we have a 21-year-old woman, and she's here in clinic. She has a history of, briefly, congenital ichthyosis, which she was born with, asthma, and chronic urticaria. And she's presenting to the rheumatology clinic because she has recurrent sinusitis and lymphadenopathy. And before I reveal more about the reason why they sent us to rheumatology clinic, I'll tell you about her symptoms. So she reports that she's miserable. She gets diffuse hives, and these come and go. They're intermittent. They occur at night, and they come on. They're really itchy. She can't stop scratching herself, and then they'll go away after a few hours. It interferes with her sleep. She feels hot subjectively, but she's not documented any fevers when she's checked her temperature. And this has really been going on for like the last 2 years or so. It's been progressively worse over the last couple of months. She also notices, in addition with this itchiness that she gets intermittently, that if she scratches an area, she will notice that she develops a rash that looks like hives in that location. Some of the relevant review systems that she also mentions is this chronic fatigue that's been getting a little bit worse, possibly that she thinks could be due to the lack of sleep from this rash and itchiness. She notices this intermittent rash on her legs that looks like vasculitis. And that occurs commonly when she goes out in the kind of the heated environment or under the sun. And then also has some intermittent abdominal pain and the sinusitis that she can't get rid of. Notable things that are negative on review systems that she mentions: she doesn't have any arthritis, doesn't have muscle weakness, neuropathy, hemoptysis, or hematuria.
Robbie, should I start it? Jeffrey, first of all, thank you for that HPI. And I have so much admiration for rheumatologists because of all of the findings that you described and trying to create a story that marries and explains the symptoms that the patient's presenting with. And I think one thing that we go through in our clinical training is to tease out signal from noise. And of course, when we're doing a virtual case, it can be more challenging to tease out signal from noise, but it's great to put some, weight on these different symptoms that then dictate which one we focus on. And because there's many symptoms, maybe I will comment on like what symptoms I think would be most useful from a diagnostic lens and what symptoms I would put in the orbit and then dance with my brother Robbie because it's such a rich aliquot. The first thing that struck me was this lymphadenopathy, because lymphadenopathy, of course, can be reactive in the context of an infection or some kind of process. But if someone has diffuse lymphadenopathy, you got to be able to explain it. And just like reflexively, when someone has lymphadenopathy, localized versus diffuse, we'll get more information throughout this presentation. But with diffuse, my question is, can I get to an answer without a biopsy, an excisional lymph node biopsy? And the most common culprits of diffuse lymphadenopathy probably would be the infectious mononucleosis, which can be caused by EBV, CMV, HIV, and less common etiologies. So almost in all comers, we end up sending those serologic tests. There can be drug-induced lymphadenopathy. We'll see what medications this patient is on. Lupus in the autoimmune category is a common cause of diffuse lymphadenopathy. And if you get an ANA and a double-stranded DNA and it's positive, someone has lymphadenopathy, I don't think you need to proceed with lymph node biopsy. Sjogren's is another common cause of lymphadenopathy, so sending the Sjogren antibodies. So that grabbed my attention. And since we're in the room world, not because of you, Jeffrey, just because of this case, we also learn, and this is the last thing I'll talk about and then pass the mic to Robbie, the rash, urticaria. Now, urticaria is very common. And Jeffrey described it perfectly. Elevated, raised rash that goes away within hours. When do we get concerned about urticaria? When it's persistent. And the finding of the patient scratching themselves and the hives occurring is really suggestive of dermatographism, which in itself, by itself, is not pathologic. Some people with urticaria have dermatographism. But when urticaria persists, or if it's happening over and over, you may want to question, is this just common urticaria, or is this a signature of a vasculitis? And she was already concerned for a vasculitis. And you also mentioned she gets exposed to sun, the rash worsens. So now I'm starting to think, does she have a photosensitivity process? So I'm going to pass the mic to Robbie to clean up and layer his brilliance, because Jeffrey, you know, Robbie is a rheumatologist and he's every subspecialist. But in my mind, I'm really worried about the lymphadenopathy. I wonder if the urticaria is something more than benign and whether there's an underlying vasculitis at play.
There's nothing left to say, Prof. Rez. I couldn't agree more with you. I think it's absolutely superb. And ultimately, I think that the interesting thing here is the combination of these things, because the vast majority of people with recurrent sinusitis have no clear explanation, and the term of chronic non-infectious sinusitis is applied. And the same is true for patients who have urticaria. The vast majority of patients with chronic urticaria have no clear explanation. But it is the mere overlap of the combination of recurrent sinusitis and urticaria that breaks the rule for both those conditions. Because part of the subliminal rule for chronic urticaria and chronic idiopathic sinusitis is there is nothing else going on. And the fact that each other is going on breaks the rules for each category. And I think that the presence of the lymphadenopathy gives further credence to the idea that you are dealing with a systemic syndrome. Because I bet you, Prof. Rez, if you crunch the numbers, recurrent sinusitis plus recurrent urticaria, even though that suggests that there's a cool underlying systemic disease, I bet you, mathematically speaking, the most likely cause would be true, and unrelated. Because overwhelmingly, the recurrent idiopathic sinusitis and idiopathic urticaria are so likely to be idiopathic, even when they occur together. You still have to open the door to a systemic disease, but I think probabilistically speaking, it's the same reason why heart failure and COPD, it's tempting to connect them, but they're independent entities. And so I think here that's where the lymphadenopathy is really powerful, because I think it says, hey, neither of those things, unless lymphadenopathy is localized, generalized lymphadenopathy is a corollary for systemic disease. So I think that gives you tremendous momentum to the thoughts that you've articulated. I don't have anything to add to them. They were outstanding.
Can I just make one quick request before Jeffrey comments? Can you share with the audience Nijad's pearl on the
Yeah.
subapathy? I think that's such a brilliant pearl.
Yeah.
Don't
He
laugh
has
too
a
hard, but that root canal, you haven't had
I
it yet.
know, right? When it's such a great pearl. Thank you for reminding me, Prof. Raz. Whenever there's my colleague who works in the ER is very, very savvy ER clinician. His name is Mike Najad, and he has a really helpful rule that whenever you have two concerns that are more than 2 to 3 feet apart, the odds are they're not related unless the patient is super, super ill. So if somebody has toe pain and a headache, yeah, sure, could have a pan aortic dissection from the top of the aortic arch all the way down down to their iliac fossa, but odds are it's the tension headache with a little bit of gout, you know? And so I think when you have urticaria and sinusitis, they're probably not related because they're pretty far apart. But I think the lymphadenopathy is the equivalent of the aorta. It's telling you that there's something systemic going on.
Wow, that was incredible. It's always nice hearing from both of you and your thoughts. But I mean, I couldn't agree more. It sounds just like, the same things that you were talking about, or the same things that were going through my head with, the thought about the sinusitis and the urticaria, and then this dangerous kind of lymphadenopathy. So this next aliquot, what I'm going to discuss is just for past history, past medical history, social history, things like that, just to see if that gives you any more clues. So overall, past medical histories, soon after birth, she was diagnosed with congenital ichthyosis, had a little bit of respiratory failure, which is sometimes seen with that condition, but then overall everything resolved and she got much better. As a result of that, she's always had kind of chronic thick skin, but it really hasn't changed in a long time. She has this diagnosis of ADHD, for which she takes Adderall for. That's been stable, hasn't changed in the last 5 years. She's got acid reflux and takes pantoprazole, also been stable, hasn't changed in many years. She has recurrent sinusitis, postnasal drip. She's had a septal deviation, hasn't necessarily had any surgeries for it, but has been on multiple rounds of antibiotics for it. Over the past year, has been on 2 or 3 different types of antibiotics. Carries a diagnosis of moderate persistent asthma as well, for which she takes albuterol. And she has a history of this recurrent hives, which is her main issue. Initially, she tried a lot of different antihistamines, so the addition of like Benadryl with famotidine, Zyrtec, Claritin. Most recently, she's been seen with an allergist. They've tried Xolair, but she had some side effects of really bad fatigue while on it, so they've just kind of paused it. Over the last 5 years, she's not really been started on any new medications except for this Xolair. And then for other past history, so no past surgical history really. Social history wise, she's a student in healthcare. She denies any pets, unusual exposures, no sick contacts, no insect bites. She's lived in the southeastern side of the United States for all her life in a suburban area. She doesn't smoke, drink, or use any drugs, hasn't traveled anywhere outside the state in the last 5 years. All of her family's healthy. There's no autoimmune diseases that run in it. And then lastly, sexual history, she's been monogamous with her one boyfriend, and there's no history of STDs.
Oh, Robbie, do you have to go? Oh, yeah, maybe I'll comment here, Jeffrey. I think Robbie's dealing with his tooth. This is really, really helpful. You know, if I'm being honest, I've never taken care of a patient with congenital ichthyosis. I think it's a skin condition. I'm not sure. I would have to like GPT it, and I'm not sure how it's relevant to this presentation. I will say when I see a history that I'm not familiar with, I just track it and I just explore, whether it can or cannot be. I don't anchor on it and I don't dismiss it. I think that's important to note. I think that's more important than to know all the conditions, et cetera, and their manifestations. When we have these conditions like urticaria, asthma, sinusitis, it just makes you wonder whether truly these are just chronic conditions that many people have, or is there something underlying that we've yet to diagnose that could explain each of these phenomenon? So I think, again, it's not so much doubting the previous diagnoses, but just taking them with a grain of salt. And I know Uncle Bob, UAB, he may use the term doubting, which is totally appropriate, but he always says you got to question, and like stuff like asthma, sarcoid, et cetera, always warrant just a little bit of a pause to reflect on the diagnostic accuracy. I see Robbie is back. Robbie, are you in a place to talk?
Yeah, one of my dentist's office is only 4 blocks away from my house, but the reason I'm in my car is there was fire alarm testing in my place, and one of Nar's least favorite dogs walked by, and he was shaking the car. So sorry about that. Yeah, Prof. Raz, I just love acknowledging the big knowledge gap here. I have no idea what the complications are of congenital ichthyositis. I can't even say it. I can't even say it, let alone acknowledge it. So yeah, I'm right there with you. All this really does for me is exactly what you said. I'm so intrigued by the fact that this patient really seems to be devastated by a phenotype of allergy in her lungs, in her skin, and her sinuses. And I think that it's interesting because I think, so there's so many people who have that phenotype of allergy that have no cumulative consequences beyond the irritation of their airways and their sinuses. But unfortunately, a subset of those patients go on to actually have structural compromise. So, if a patient with asthma then goes on to destroy their airways and get bronchiectasis as an example, you might suspect a more sinister form of that asthma with allergic bronchopulmonary aspergillosis or aspirin-induced respiratory disease. And so I'm really interested in trying to represent this as, is this a pure atopic fingerprint where the patient has just allergy alone? Or has she progressed to actually destroy the tissues in those area, not just be hyperreactive? And it changes the calculus radically if we learn that she has bronchiectasis, as an example. And the reason I'm starting to worry about her is because she has the septal deviation. Now, is that another unrelated entity, or is that a proof of marker of actually destruction of tissues? So that's the only thread that I'm inclined to work with here. I think we both and all of us see a lot of patients who have the atopy phenotype, and that is severe. But the severity doesn't always lead to a specific underlying diagnosis. But when it's severe to the point where it's destructive to the local tissues, leaving a permanent scar rather than a transient hyperreactivity, is when I worry that there's something uh, alarming going on. I'm curious what your mind did with that, or yeah.
Zero to add. That's beautiful. I love that, man. Really.
Again, I love listening to your clinical reasoning, the thought process. Couldn't agree more with, how you're thinking, and always learn something from you guys. So I think the next aliquot, we're going to talk a little bit about the exam and some of the imaging to let you know a little bit more about what's going on with her from an objective standpoint. So on physical exam, she's a little bit tired appearing, but no acute distress. HENT exam, she has some tenderness to the palpation of the sinuses, but no nasal or oral ulcers. Cardiac exam is regular rate and rhythm, otherwise normal pulses. Uh, Pulmonary exam essentially is the same. She has a little bit of mild end expiratory wheezing, but otherwise no work of breathing, no accessory muscle use. Um, Abdominal exam, again, not really remarkable. It's soft, non-tender, no palpable masses. Skin exam is kind of interesting. So she does have this diffuse skin thickening, which I assumed on exam was related to her ichthyosis. It is symmetric and it is a little bit thicker over the forearms, the lower legs, the axilla, and the groin. Maybe a little bit thicker in like the creases, so axilla, groin, the flexural creases of the knee and the elbow. She does have this urticarial appearing rash that's over her bilateral breasts and upper back, as well as her right forearm. Currently, there's no vasculitic appearing rash. There's no purpura. There's no petechiae. So that's the skin exam. Lymph node exam wise, I was able to palpate smooth axillary and inguinal lymphadenopathy, but really it was pretty mild and there was almost no tenderness. Otherwise, I couldn't really palpate any other lymphadenopathy. MSK exam. So, as a rheumatologist, we always have to do a MSK exam, even though she doesn't complain of arthritis. But essentially, it was normal. She's got full range of motion to all joints. There was no synovitis or kind of occult synovitis there. And then the next part of this outclot, I'll just briefly talk about her imaging, which is a CAT scan of her chest, abdomen, pelvis. So essentially it was normal except for having bilateral axillary and inguinal lymphadenopathy. There's nothing else, no suspicious lesions, no pulmonary nodules. Everything else was read as normal.
Jeffrey, maybe I can. Oh, are you still presenting? So sorry. All right, good pause point. I'm going to pass the lymphadenopathy to Robbie to comment on. Maybe I can just talk about the ichthyosis. And the reason I can talk about it is I remember there was an NAGEM picture, a NAGEM CPS, Robbie, by Alan Gelber. Do you remember that one? Where the patient presented with ichthyotic skin. And I just looked at my Glass Health note page on this. And basically, ichthys means fish scale in Latin or Greek. And it's just like thickening of the skin. And I I think this one is congenital, but if it weren't congenital, common causes include HIV, Hodgkin's lymphoma, sarcoid, and nutritional deficiency. So I'm just starting to think like again, this was from birth, but if it wasn't and we had lymphadenopathy and this skin condition, maybe sarcoid and HIV, maybe prioritized. But I'm going to pass the mic to you to talk about the lymphadenopathy.
Oh, Prof. Rez, that is such an epic DDX. I had completely forgotten about that. I have to refresh my mind. I have like no DDX for ichthyo. I can't even say the word. Yeah, I'm glad you know that because it certainly sparked some thoughts about the lymphadenopathy when you mentioned lupus and sarcoid. I think both of them would be, or I think you only mentioned sarcoid, sorry, and HIV and sarcoid. Both of them would be great fits for lymphadenopathy. And I think here the time course of the lymphadenopathy is very, very powerful because I think that if you think about all the things that can cause lymphadenopathy just fundamentally means that the immune system is activated. And I think here we know that since the patient has widespread lymphadenopathy, this is widespread immunological activation. And the truth is that the nature of the immunological activation in lymphadenopathy is often either infectious or malignant. And we really try to figure out, is this mono or is this lymphoma? And so we might actually layer on the fact that we have lymphadenopathy without any focal source. There is no pulmonary lesion, there is no intra-abdominal lesion. This is just lymphadenopathy with the center of gravity viscerally being just lymphadenopathy alone. And so I think that could this be a metastatic solid cancer to the lymph nodes? Unlikely because there's no solid focus. Could this be an infection going to the lymph nodes? Much less likely because there's no solid focus. And so I think that's where you have license to jump into the less common but well-described causes of lymphadenopathy, which are the autoimmune conditions because they tend not to have a radiographic imprint outside lymph nodes. So lupus, for example, to give you a non-classic form of lymph node disease, you'll have many, many clues outside the lymph nodes, but it won't be radiographic clues. Sarcoid, as another example, you'll have many, many clues outside the lymph nodes, but it won't be radiographic clues. In fact, radiographically, sometimes all you see is lymphadenopathy. So what am I really trying to say? I think when you have systemic lymphadenopathy, you're thinking systemic immunological activation, priority infection or cancer. But in the vast majority of instances, the lymphadenopathy will not be the only feature that you see radiographically. You'll see a pocket of miliary nodules to suggest TB or histoplasmosis. And you'll see a solid cancer. So what are really important exceptions to these rules? Lymphoma or Castleman's disease for the lymphadenopathy and malignant. And then in terms of the infections, what are the two important infections to always think about that cause widespread lymphadenopathy without a visceral imprint? I think HIV and syphilis. And so I would be trying to, trying to get those tests. And then beyond that, I think that's when you move into the autoimmune causes. And so I don't think I would move into them quite yet beyond getting the two fundamental tests, which is an ANA and a serum protein electrophoresis. And so, yeah, I think here the lymphadenopathy is very intriguing. If we label it as chronic lymphadenopathy without a solid organ focus, I think that really helps us make a lot of progress. I don't know how to link it to the skin. I don't know how to link it right now to the urticaria, but I'm really, really eager to see how this all starts to integrate together. All right, Jeffrey, what do you have next for us?
Awesome. I mean, thanks so much for that. So again, a lot of this is cheating for us, and you'll see why, because by the time that a patient sees rheumatology, they don't have to necessarily have gone through all this thought process, since we have the labs that are ready for us. So this next alcohol is going to be the labs, and I'll explain like why they actually got referred to us. So let's start with the CBC. There's a white blood count of 12,000, and there's 35% eosinophils. So that comes to an absolute eosinophil count of about 4,200. 17% lymphocytes. H&H is relatively normal at 14.4 and 42. Platelets are normal at 304. On the CMP, most of it is normal, but I'll give you the lab. So 138 sodium, 4.3 potassium, 105 chloride, 26 bicarb, 9 for BUN, 0.7 for creatinine. The albumin is 3.8, but the protein is elevated at 9. Total bili is at 0.3, AST is at 42, ALT is at 33, alk phos is at 82, calcium is normal at 9, and glucose is normal at 104. So essentially, the CMP is mostly normal, some hyperproteinemia. UA was performed that was negative for proteinuria and hematuria. And there was also, and that included a urine protein creatinine ratio that was essentially negative for proteinuria. And then there's a urine drug screen test that was also done, which was negative. The other labs that were done included a lot of infectious labs and rheumatologic serologies. So from the infectious side, we have negative cultures from the blood, urine, and sputum. They sent tests for HIV, syphilis, hepatitis B and C, as well as the quat TB, and those were negative. They also sent for histoplasma urinary antigen, as well as blastomyces and coccidiomyces serum antigen, which were all negative. And they also sent for serologies of strongyloides, which was negative. So those were the infection labs. And then finally, for the rheumatology labs, the ANA was positive at 1 to 160, but the rest of the panel, including double-stranded DNA, Smith, RNP, those kinds of labs, there's a full ENA panel, was all negative. They checked complement levels for C3 and C4. C3 was 84 and C4 was 9. Those are both normal levels. Sorry, C3 was 84 and C4 was 9.4, and those are both slightly low. The normal levels for C3 are 90 and C4 are 10, so like barely borderline low. They checked in ANCA, MPO, PR3, and those were all negative. They also checked a rheumatoid factor and an anti-CCP for rheumatoid arthritis, which were negative. Inflammatory markers were checked, which ESR was slightly elevated, it was at 40, normal as under 20, and CRP was 1 mg per liter, which is normal with the cutoff being 10. So a little bit of high ESR, normal CRP, and then we had immunoglobulins that were checked, and the IgG4 was 1,155, and normal for that is 121, with a total IgG that was elevated at 2,785, normal is about 1,600. They also checked an IgE level, which was also very elevated at 2,620, normal is 270. So the referral to rheumatology is essentially, could this be IgG4 disease?
Oh my gosh, I'm so glad we're here. Trevor, this is such an incredible case, and I think that, of course, the storytelling that a seasoned rheumatologist is sharing with us is so engaging, so I really, really appreciate that. All that I will try to do is to set all of you up to enjoy a Prof. Res masterclass about eosinophilia. So I will pass that to him. All I want to try to do is to tell you why it matters so much in this patient and why it usually doesn't matter in most people. And in most people, eosinophilia, strictly speaking, is over 500 eosinophils. It starts to get moderate when it's over 1,500, and it gets severe when it's over 5,000. And I will tell you that, just like we talked about lymphadenopathy, what lymphadenopathy is immunological activation. And the same is true for eosinophilia. In the world of lymphadenopathy, we talked about how infections and cancers get prioritized. But in eosinophilia, the question is what gets prioritized? And I will tell you, you shouldn't even answer that question or ask that question when you have low-level eosinophilia, because the vast majority of patients with low-level eosinophilia do not have a concrete answer. And so that using the eosinophilia as a clue in cases where it's not high is literally a waste of your time. There's only a few instances where eosinophilia should grab your attention, and it's often related to the severity. And here, I can do this math publicly. 1/3 of 12,000 is a very high number, way above the 500 to 1,000 of non-specific low eosinophils. So I think for that reason, you should listen to what Prof. Rez has to say. Otherwise, what he's about to teach you doesn't apply when the eosinophils are much less impressive.
Man, thank you for the setup, Ravi. Really appreciate you, man. And Jeffrey, I wish all presenters were as kind as you. All I can look at is your smile as like we're talking. And you're epic. Thank you so much for being here this morning. And what Robbie just said is so important. And I think that's something else we learned through our medical training is not looking at lab values as normal or abnormal, but really putting a mark on their severity and when should we be concerned. And following the thread that we started in the first aliquot, signal versus noise, we said that the lymphadenopathy has to be explained. And now we're saying that the eosinophilia must be explained. Because what's causing the eosinophilia is also causing the lymphadenopathy. Now with eosinophils, Robbie already categorized it as like moderate to severe eosinophilia. You have to ask the question, are the eosinophils infiltrating organs or not? And I will say this too, even like with the prior aliquots, what we were worried about is like a widespread infiltrative process. Just when you say sinus, lungs, lymph nodes. It's so easy to remember where eosinophils infiltrate. I learned this from Robbie, is basically the organs exposed to the environment. Lungs, she has this asthma. Skin, she has this urticaria. The GI tract, and then one internal organ, which is very important, the heart. This is where eosinophils can cause damage. And remember, just even if the eosinophil count wasn't this high, it is still possible that they're infiltrating tissues. Now the question becomes, is the damage we're seeing due to the eosinophils, or are they due to what's driving the eosinophilia? That distinction is critical. It's very important. But the only way you make that distinction is thinking about the secondary causes of eosinophilia. So with any kind of CBC abnormality, it's either primary or it's reactive or secondary. And when you think about the secondary causes of eosinophilia, it's easy to rule out some of them. For example, adrenal insufficiency would never cause an eosinophil count this elevated and wouldn't cause all these symptoms. Additionally, allergic causes. Yeah, definitely people who have atopy can have high IgE, have high eosinophils, but this degree, in my mind, is way beyond the typical eosinophilia we associate with typical atopy. Now, there are some other allergic disorders like drug-induced hypersensitivity syndrome, aka DRESS, or acute interstitial nephritis that can have an eosinophilia, more the drug-induced, and that's in that allergic bucket. Then you're left with infections, and this is where it's really cool because your typical infections, the bacteria, they don't cause eosinophilia. In fact, they cause eosinopenia because you get endogenous steroids, and eosinophils are exquisitely sensitive to any kind of steroid, exogenous or endogenous. It's really the fungi and the parasites. And we do have some serologic workup, and that's where epidemiologic clues are quite important. And I'm glad that they tested for strongies, because that worldwide would be a very common cause of eosinophilia, lung disease, some GI discomfort. Then you get into malignancy, and it's not all malignancies, it's lymphoma and solid cancers of those same organs. The GI tract can be linked with the eosinophilia. But this is really high eosinophils. And if this were a lymphoma, you might prioritize something like a cutaneous lymphoma that is, now widespread to the lungs, et cetera, but it's definitely on the differential diagnosis. And then your autoimmune category. How can I forget about that looking at you, Jeffrey? And the main culprit there is EGPA. Now, what's interesting is with EGPA, in most autoimmune diseases, they most commonly occur, the EGPA, the GPA, et cetera, in middle-aged individuals. And they often have a fingerprint on the lungs, maybe the kidney. I would definitely get a UA and a urine protein to creatinine ratio just to make sure that there isn't any evidence of GN. And they can involve the sinuses, more common GPA to involve the sinuses. But EGPA, if you say asthma, you say rash, you say eosinophils, and then you throw in the kidneys, is always a possibility. Then you're left with the primary causes. And here, it's primarily an issue with the mutation of a hematopoietic stem cell leading to hypereosinophilic syndrome, where the whole problem isn't a secondary cause that's leading to lymphadenopathy, et cetera, but the primary bone marrow process. And the only way you can diagnose that is do a biopsy and then look for the gene mutations for the hypereosinophilic syndrome. So to summarize, Jeffrey and Robbie, I think whenever you have this degree of eosinophilia, you have to ask the question, is the eosinophilia doing the damage to the organs or the secondary process? In all comers, you're going to evaluate for infection. But like Robbie said, the fact that there's nothing in the lungs on that CT scan really lessens the likelihood of fungal infections, which often are acquired through inhalation. Further, we don't really have epidemiologic risk factors for other parasitic infections. Lymphoma is always going to be on the differential. I don't think anyone can say it can't be lymphoma. And this ANA of like 1-to-1 doesn't really impress me too much. This immune system is quite active. If you go and look at the population, I think up to 20% will have like a 1-to-40. The titer is just not that elevated. So the question is, where do we go from here? Well, you're going to get a peripheral blood smear. You're not going to rush to give steroids, but you're going to be thinking about it. And I think, like, honestly, I actually want to pass the mic back to Robbie, because like the question, like we did with the lymphadenopathy, is can we get an answer without having to do an invasive procedure? And I'm not sure we can. I know, I mean, we would send ANCA, but they're not, sensitive enough or, to rule out those diagnoses. We'll send the UA, but I feel like ultimately a biopsy or tissue analysis, histology is going to be vital. But I want you to comment, my friend, and see what you have to say.
Yeah, I completely agree with you, Prof. Rez. I think if we put before us the infection, autoimmune, and malignant categories that you outlined, I think there is no infection that I can think of that wouldn't be diagnosed serologically in this circumstance unless you do a biopsy that shows a bug. So I think your only hope for infections is to do a serological analysis, which I think is largely complete with the fungi and parasites that Jeffrey outlined. If you were to visit the autoimmune category with EGPA and IgG4 disease being the most prominent rheumatological causes, I think that both those conditions are biopsy-based conditions, and that's because the p-ANCA serology for EGPA is at best 50% sensitive, depending on who you talk to, but usually less. I think the value of imaging for IgG4 disease can't be underemphasized. And so here, even though the IgG4 levels are very, very high, the specificity of those levels for IgG4 disease is no more than 60 to 70%, meaning that 30% of people with very high IgG4 levels do not have IgG4 disease, a very high number. And certainly that number has to be higher in this patient for two reasons. The degree of eosinophilia is not usually this high in IgG4 disease. It's mild eosinophilia at best. And also the lack of radiographic evidence in the kidneys and the pancreas and in the salivary glands. So we didn't hear of a patient who has parotitis, salinitis, pancreatitis, or retroperitoneal fibrosis. So I think that that IgG4 disease has no other investigations left apart from also biopsy. And then the same is true for the cancer. And the cancer is either a primary bone marrow cancer, in which case a bone marrow biopsy would be elucidative, or a lymph node based malignancy like a lymphoma or Castleman's disease. So for me, I'm looking at this and I'm saying, how can I make more progress And I think the only way I can imagine making progress is if the smear shows evidence of myeloid dysplasia or myeloid features, in which case that would profoundly support a bone marrow issue. I can also see flow cytometry being supportive here, because if you see an abnormal lymphoid population, you might diagnose lymphoid hypereosinophilic syndrome. If those two serological simple serological investigations don't bear fruit, I think it's hard to imagine a circumstance where you don't biopsy the lymph node or biopsy the bone marrow. And I just have to say the mild and minimal nature of the lymphadenopathy and how small they are is very, very concerning to me, in that they may not be juicy enough for a diagnostic yield. So, as is true in many cases of eosinophilia, all you can do is rule out many things and then end with idiopathic hypereosinophilia, where you cannot distinguish between ANCA negative EGPA and a primary mutation negative hypereosinophilic syndrome. That, like, ultimately you do all the tests, but it is impossible to distinguish between a pre-vasculitic EGPA and hypereosinophilic syndrome. So I think biopsy is the name of the game. I don't know if I would biopsy the lymph node or the bone marrow first. I think it would be a really, really tough one. Jeffrey, I'm nervous.
Awesome, awesome. Well, I'm still kind of cheating still, because these biopsies were actually done before I got to see the patient, and this is going to be interesting. So I have 3 biopsies for you, of a sinus biopsy, a bone marrow biopsy, and an excisional lymph node biopsy. So we're going to go with the simplest one, the sinus biopsy. It just showed non-specific chronic sinusitis. There was no great deal of eosinophilia, and there was also no great deal of IgG4 cells. Cytology and culture are negative. So that one's out of the way, quite simple. Bone marrow biopsy was also performed, and it showed a mildly hypocellular marrow with marked eosinophilic hyperplasia, but there was normal trilineage hematopoiesis, no increased blast, there was no atypia found. And the flow cytometry as well on the bone marrow was negative for any abnormal myeloid or lymphoid cell population. They also did cytogenetics, next generation sequencing, FISH studies looking specifically for mutations corresponding with hypereosinophilic syndrome. Those were all negative. And then finally, the excisional lymph node biopsy was read as reactive follicular hyperplasia. I'm going to tell you a little bit more detail, just in case it helps anybody, but it shows a nodular follicular architecture, and there was a mixed infiltrate, primarily, or most of it actually was in the paracortex, and it was an interstitial infiltrate of different lymphocytes, eosinophils. Eosinophils were increased, but there were no atypical cells again. There were no atypical lymphocyte cells. There was a mild increase in IgG4. It was much less than 40%. And there's nothing else that looked like IgG4 disease on the lymph node biopsy. The accompanying flow on the lymph node biopsy was also negative. And this is the final aliquot before I reveal the final diagnosis.
Well, thank you so much, Jeffrey, for telling us all the pathologic hallmarks of the biopsy, though not sure how we're going to be able to utilize those words that you shared with us, though I think you shared them for a specific reason. I'm going to just share some general principles and then pass the mic to Robbie. Whenever someone gets a biopsy, there's like 3 possible outcomes. Either there's good news, meaning that you've ruled out a malignancy, for example. There's bad news, you diagnose them with a malignancy, or there's no news. The no news is a really important category to consider, meaning that even if the biopsy is negative, it doesn't mean that there isn't something there and we just didn't sample the right segment or the right section. And then for that category of diseases, you'll know the yield of biopsy is different. For example, when someone with Hodgkin's lymphoma and you're searching for those Reed-Sternberg cells, it might be difficult to identify. Or if you're looking for amyloid in the heart and you don't get the right spot, you may miss it, for example. So that's one thing to consider. The other thing to consider here is that it seems like the marrow is extremely stimulated to make eosinophils. There's something that's driving that marrow to make eosinophils. And the sinus issue, though, seems to be just sinusitis, like run-of-the-mill sinusitis, because there was nothing that was identified on that biopsy. So now what my mind is doing is asking, the question, is this idiopathic hypereosinophilic syndrome? And does this patient just need our favorite medication that Robbie and I like to say, some steroids? And then you give the steroids, see how they respond. Or is this some less common cause of lymphadenopathy and sinusitis? You know, um, and that's when you get into those buckets of disease. I just don't have the most robust illness script for them. But for example, Rosé-Dorfman disease comes with sinusitis and comes with lymphadenopathy, but I just don't know what the age group is. So I'm wondering, is there some other lymphoproliferative disorder that's not lymphoma that I just don't know because it's so rare that's driving this? And maybe Robbie knows, and obviously Jeffrey does know. Or is this at the end of the day just idiopathic hypereosinophilia? So Robbie, Mike, to you, my friend, to see if there's anything that popped out to you on that pathology results. Otherwise, very excited. I was only supposed to be here till 9:30, guys, because I have a doctor's appointment, but I'm gonna stay until we get this answer.
I was like, I'm not gonna tell him or ask him. I'm just gonna see how much gem we have we get today. Prof. Rez, I'm just gonna show people a visual that outlines exactly what you just said, really, but just to have people have a visual. So I'll just borrow the screen for a moment. So when you have cryptic eosinophilia, meaning you've done the workup and you don't have an answer yet, you can get clarity by getting lucky and getting a positive ANCA, an ANCA positive GPA, or you can get clarity by getting a mutation positive in your bone marrow biopsy, or you find a cancer on the excisional lymph node biopsy. We haven't done that. So now we're not just cryptic, we're ultra cryptic. And ultra cryptic means that you either have hypereosinophilia from a specific end organ disease like eosinophilic pneumonia, which is usually when you have disproportionate disease in that specific organ. So that's not at play. So we're either dealing with ANCA negative eGPA, idiopathic hypereosinophilic syndrome, which, as I mentioned earlier, are not distinguishable until you watch the patient evolve, or you have an occult paraneoplastic process that you missed on your lymph node biopsy. And so the first question really is, what are the cancers that you can miss that Prof. Rez was talking about that produce this degree of eosinophilia? And the cancers that do that really are, at least to my knowledge, this is what I've been able to put together based on cases and reading. And so I think we all have heard about how evasive Hodgkin's can be, how evasive angioimmunoblastic T-cell lymphoma can be, and how evasive Castleman's can be. For something to be evasive for this long, I think Hodgkin's and Castleman's are the only things that are reasonable, because everything else on here is usually a little bit more bold and not lingering for 2 years. And so practically speaking, all that I can really offer Prof. Rez right now is, those lymph nodes were small and shoddy, and so do we need to do another lymph node biopsy is the only open question that I would have. But I think now it's a time to really suppress the immune system and suppress the eosinophils and see what happens. I think if you were lucky enough to ask the patient to get a picture of the rash that she had that she described as vasculitic, and if that convinced you that in fact she did have a vasculitic rash, you might start to lean in and call this presumed ANCA negative eGPA owing to vasculitis. But the truth is I'm starting to now feel like I'm about to make things up. So I will stop talking and hand the mic to Jeffrey for him to teach
Now
us.
you know how the rest of us feel, but much earlier, Robbie.
All right. Well, I mean, those are such excellent clinical reasoning things, and I totally would be on the exact same path when I was evaluating the patient, thinking the exact same things. Like, it's kind of one of the patients that you get in rheumatology. You're like, this is really complicated, and 9 or maybe more than 9 times out of 10, you don't end up with a diagnosis. But for her, what we ended up doing was whole exome sequencing, specifically looking for congenital ichthyosis mutations, and she was positive for SCL27A4 mutation. And that condition causes congenital ichthyosis prematurity syndrome. That syndrome starts with premature birth, Then within the first week causes congenital ichthyosis. The ichthyosis and the respiratory insufficiency gets better after the first few weeks. And then patients are afterwards have severe or mild to severe, depending on the mutation, chronic thickening of the skin or ichthyosis, but also dramatic hypereosinophilia can occur. And I guess it can occur at any time with accompanying manifestations of atopic manifestations, so asthma, things that you would commonly see with eosinophilia, like hives. We looked again at the lymph node biopsy, and I kind of honed on the paracortical is because I wanted to know whether it was maybe reactive but due to her skin. So when I re-reviewed the results with the pathologist, they said it would be consistent with something called dermatopathic lymphadenopathy, which is this kind of, for lack of a better term, thought to be just a reactive lymphadenopathy due to skin inflammation. And the areas, interestingly, on my exam that were like more severe, like the axillary and inguinal spots, were the places where she had the most lymphadenopathy. So that was really interesting. So in the end, we got her this diagnosis, but unfortunately, there's not really much known about how to treat it. It's mostly really good skin care. For the hives, we're starting her on Fasenra, and she's actually getting that and methotrexate, and it's had significant improvement on that regimen. Her lymphadenopathy is still there, but it's a little bit better. IgG4 levels are still elevated, but maybe a little bit better. But her symptomatically and clinically, she's feeling much better, and eosinophilia is gone. So very interesting case. I think I learned a lot actually just from you guys thinking through the case, because for the majority of it, I actually had information about biopsies and labs and things. So I enjoyed that a lot. I think from my perspective, a lot of the points that you guys said, I'll just kind of restate. So from an autoimmune perspective, just as I think Rabih mentioned, the two, or maybe it was Reza, the two big ones we were thinking about, like, could this be IgG4 or EGPA? And and multiple people in the chat, and I think Reza also mentioned that, or I can't remember exactly who mentioned it, but somebody mentioned that true, you can have EGPA. It's very hard to diagnose. That is ANCA negative, and in my experience, that's again like 50% or more of the time that is true. So we were like this close to making an EGPA diagnosis. But I think one thing, just from my clinical reasoning perspective, is if you have a patient where you don't have a better explanation, I think a lot of clinicians and learners tend to say, well, we don't have a better explanation, so it has to be this diagnosis. In rheumatology, from my experience, that is not how we would approach things. We would rather give a patient no diagnosis and monitor them rather than giving them the best closest diagnosis. Because sometimes, and most of our diseases, actually, it takes time for the manifestations to fully appear. So I think a good part here was like being very close to giving this person an autoimmune diagnosis, but not giving her the diagnosis. And then I happened to just, one of my interests is in clinical reasoning and, like undiagnosed diseases. So I was just really curious, as Reza mentioned, like when you don't know anything about ichthyosis, look if there's anything related to that. And I happened to find when you put in ichthyosis and hypereosinophilia, this specific mutation. So I was like, well, I mean, 9 times out of 10 it's not going to be that, but this is the time it is that. So yeah, thank you so much for having me here and share this really fascinating case with you guys.
Rob, okay. Jeffrey, I have zero to add. I just want to say that I wish all doctors were like you in terms of when they don't know something, to just be bold and say they don't know, like what's going on. Otherwise, patients carry wrong diagnoses, leading to harm. And then Rabih, I'm just so proud of us. Like, do you remember the case that Emily Silverman presented to me, where she said the patient had dystrophic nails? And what did I do when she said that? I jumped over it. I didn't talk about it because I had no clue what that meant. And if I would have just said, hey, yellow nail, and then I had the word syndrome, I would have got yellow nail syndrome. This is it, but we didn't shy away this time. We didn't pretend like we knew anything about ichthy. You can't even pronounce the word, and I'm not going to try to pronounce it right now. But we did say we don't know if it's relevant or not. We don't want to anchor, but we would look it up. And I think that's the power of clinical reasoning. So like, awesome to just see our growth, man. Really awesome.
Yeah, 100%. I think we have everybody fooled that they're growing a lot by being here, but I think the truth is that we're growing the most, and I think I couldn't agree more with that. And I think our growth is fueled by people like Jeffrey who come in here with present such incredible cases. And you know, Jeffrey, what I loved about your presentation is I think that at the end of the day, if I were presenting this case to people like me and Reza, I know that I'm probably gonna not, they're probably not gonna know the answer, right? Because you know it's a very very like niche diagnosis that if you happen to bump into it, great. But I think that the way you set it up and how you taught us and the humility that you projected about the fact that you didn't have to do this clinical reasoning yourself made it an incredibly educational session. Because I think most of the time when you're discussing these things and you know that you've never heard of the answer before, it tends to be a wobbly discussion. And I think the fact that it was such a linear path till the end until it wasn't linear at all makes it such that we can all learn from the core features of eosinophilia and then add something else that's completely new rather than just be confused and spinning our wheels. So I really, really appreciate this. And I will tell you, I think it would be awesome to see you here reasoning with us. It would be a real, real treat. So thank you so much. I do want to pass the mic to you to take a benefit from your expertise, and then Gerardo, just to emphasize maybe the 2 or 3 teaching points that you want everybody to walk away from, and then we'll have Gerardo do the same.
So yeah, again, thank you so much. I'm really glad to be here and love to have more opportunities in the
I think
future.
Robbie doesn't care about my health. Now I have to stay for these 3 teaching points. It's my appointment. Jeffrey, make it quick.
Well, it's gonna be pretty simple. So I think the first thing is, you know, the original question of IgG4 plus lymphadenopathy should never be treated as IgG4 disease when the only or primary manifestation is lymphadenopathy, and neither does a lymph node biopsy, even if it was diagnostic for IgG4 disease, give you that diagnosis. It's much more common to have an elevated IgG4 and diffuse lymphadenopathy from a diagnosis that is not IgG4 than for it to be from IgG4. So I think that's really important. When you're thinking about syndromes, second teaching point, I guess, is when you think about syndromes that have many different manifestations, it goes back to my point of instead of going with the disease or a diagnosis that could explain it, but you're not sure, just put a little bit of a pause and tell yourself and the patient, let's monitor you and make sure that when new symptoms develop, we can reevaluate it. So I think those are like the 2 major teaching points. For me, I think this case, I was lucky that we ended up having a diagnosis, but I think another teaching point is we ended up even if let's say we didn't get that diagnosis, we may have eventually still chose the correct treatment for this patient with this line of thinking that Reza had, that could this just be some idiopathic or unknown lymphoproliferative disorder that we can't name, and we still may have chose the correct treatment and she would have gotten better. So I think that's another great teaching point to think about for this case.
Absolutely amazing. Gerardo, I would love for you to teach us for the next 49 minutes so Prof. Rez can't make it. I'm just kidding. I'm kidding. Mike is yours, Gerardo. Take it easy, Prof. Rez.
Thank you so much, Ravi, for passing the mic to me. And yeah, so I think this was a very complex case, but thanks to you guys, I think we saw the value of clinical reasoning. And for me, the main teaching points that I get from this is that when you have a constellation of signs and symptoms and that seem to be unrelated, then you have to apply clinical reasoning and you have to really analyze what can in a common ground that you have, because sometimes you don't have common ground. So in this case, the common ground that we found initially was, is it asthma plus sinusitis plus urticaria a syndrome? Is it caused by one single thing, or are they separated? And then you mentioned one very important thing, which is asthma is accompanied by destruction of tissues. Is it sinister? Because we do have to ask to ask ourselves if a disease could be sinister, because then we can establish treatment. And then ichthyosis was a word that popped, and we really had a hard time trying to analyze it. But then we just identified that it can be understood in its basis, which is a thickening in the skin. And then we proceeded to analyze lymphadenopathy and eosinophilia, and the combination of those signs and symptoms led us to the final diagnosis, which was really aided a lot by secondary exams, which is really a sign of current medicine, right? For the really special diagnosis that have a low base rate. So those are my teaching points, and thank you so much.
Outstanding job. I love how crisp they were. You hit the highlights. And I completely agree with you. It's incredible to have these very advanced tools that allow us to be so precise exactly where the gene mutation was that caused this syndrome. A real treat. Thank you so much, Jeffrey. Thank you so much, Zachariah, for scribing, Gerardo for the great teaching points, and of course, Prof. Rez. All right, guys, have a great rest of your week.